Hello, my name is Mike Carlson, and I am presenting SOAP Note Week 4 for a geriatric cardiovascular event. Had a patient, ID LF, date of birth 5/23/46, 79-year-old male, arrives to the urgent care clinic with family, appears to be in good hygiene and able to self-report. The chief complaint patient states, I have been having some chest pain when I take a deep breath for the last 2 days and I'm feeling short of breath. HPI patient is a 79-year-old male who presents to the urgent care this evening with complaints of chest pain upon inspiration and shortness of breath over the last 2 days. Patient states that his chest pain is on both sides under his rib cage. Patient states that it has been progressively getting worse over the last couple of days with increasing shortness of breath. States his pain is a 3 out of 10 on a 10-point scale and a constant nagging feeling, and that breathing in heavily during activity makes it worse. Patient states that when he is at rest, it isn't as bad as when he gets up and moves. Patient states the discomfort in chest doesn't move, but rather stays in one place. Patient denies any worsening symptoms, day or night, just progressive over the last couple of days. Patient has a history of BPH, Parkinson's disease, and chronic kidney disease. He's got a surgical history of bilateral knee replacements, a right hip replacement, cholecystectomy, and a tonsillectomy. No known drug allergies, seasonal or environmental allergies. Patient is on carbidopa, levodopa, tamsulosin, losartan daily. Patient states having his Tdap shot 3 years ago and received the flu shot back in October of 24. Denies any use of tobacco products, e-cigarettes, denies any alcohol use, and denies any illicit substance abuse. Family history only stated a mother deceased at age 84 due to a stroke, and had a father deceased at 72 due to an MI. As far as review of systems, constitutional patient states increasing fatigue, no weight loss, chills twice in the last 2 days. Denies HENT, denies any pain, tenderness, or hearing loss. Patient denies any soreness in his throat, denies any difficulty with drinking or swallowing. Cardiovascular states having chest pain bilaterally, denies any palpitations or tachycardia. Reports shortness of breath with exertion, occasional cough that is non-productive. Integumentary denies any rash, pain, or masses. Neurologic denies any sensory loss or migraines, however does have tremors from PD, Parkinson's disease. Patient denies no reported bruising or bleeding, denies any swelling. Endocrine denies any hair loss, skin is warm and dry, no night sweats reported, and denies any thoughts of self-harm or suicide, and his PHQ is negative for depression or anxiety. Patient's vital signs, 99.7, pulse 78, respirators 17, BP of 133/77, with an O2 sat of 91% on room air. Again, 3 out of 10 pain. He's 85.9 kilograms, 183 centimeters with a BMI of 24.9. So for this patient, we performed a CBC, a CMP, troponin, D-dimer, BNP, and radiological studies included a 2-view chest x-ray lateral AP. The physical exam, constitutional, stable weight from his last visit, fatigue noted, low-grade fever, and no chills. HENT, head's atraumatic normal cephalic, eyes show a clear conjunctiva, pupils are equal and reactive to light, tympanic membranes clear with no evidence of edema or erythema, and no evidence of hearing loss. Cardiovascular, regular rate and rhythm, no murmurs, no gallops. ECG showed normal sinus rhythm with an occasional unifocal PVC. Respiratory, lung sounds were versicular in the upper lobes, however, I noted crackles bilaterally in both lower lobes. No acute visual signs of distress as far as respiratory effort or shortness of breath were noted. Abdomen was soft, non-tender, no masses appreciated, audible tympanic resonance, musculoskeletal, had full range of motion in all extremities, no joint swelling, tenderness noted. Skin was pink, warm, and dry, no rashes, lesions, or discolorations. Patient is alert and oriented, bilateral focal upper extremity tremors, however normal strength, and sensation with good CMS. Hematologic lymphatic, no lymphadenopathy, and no signs of bleeding or bruising. Endocrine was assessed via the CMP and decreased GFR of 36 due to his chronic kidney disease. BUN was 22 with a creatinine of 1.97. So for differential diagnoses, the first one was pneumonia. The patient presents with bilateral, or rationale, patient presented with bilateral chest pain, shortness of breath, recent history, low-grade fever. Given that the crackles were noted on auscultation, especially in the lower lung fields, which could be indicative of an infectious process such as pneumonia, the non-productive cough and shortness of breath with exertion raises suspicion for a respiratory infection. In addition to patient presentation, chest x-rays show bilateral lower lobe opacities and consolidation, highly indicative of pneumonia. Secondly, I was thinking PE. The rationale was because of the shortness of breath, chest pain, and increasing fatigue, which might suggest a PE, especially in the context of progressive shortness of breath with exertion. The pain described is not sharp. The fact that it worsens with activity and the patient age raises concern for PE. However, we did do a dimer, and that showed 0.12, which was a negative result. Given the positive chest x-ray and negative D-dimer makes diagnosis PE less likely. Pericarditis, rationale, pericarditis, which is the inflammation of the pericardium, may present with chest pain that is pleuritic, worse with deep breaths, which matches this patient's complaint. In elderly patients, the risk of pericarditis increases, and it could be triggered by viral infections, autoimmune conditions, or previous MI. The patient describes the pain as nagging and constant, worsens by deep breaths, aligns with this diagnosis. However, the lack of radiation or a specific location for the pain doesn't rule out pericarditis in the presence of a fever, although low grade, could be consistent with inflammation. But given this patient's EKG results showing non-pan ST elevation and a positive chest x-ray showing bilateral opacities with consolidation, makes the diagnosis of pericarditis less likely. So I went with a clinical diagnosis of pneumonia, and given the patient's symptoms and utilizing the pneumonia severity index, or PSI, and a score of less than or equal to 70, which his score was 30, outpatient care was recommended. Treatment, given the chronic kidney disease history, went with antibiotic treatment for this patient for Augmentin 875/125 PO BID for 5 days, plus azithromycin 500 milligrams, PO once, then 250 milligrams for the following 4 days. Educated the patient on the need for the antibiotics and how to complete the full course, even if he was feeling better. Also discussed the importance of hydration, rest, and good nutrition to support recovery. Regarding this patient's diagnosis of Parkinson's disease, also emphasized the importance of continuing his medications as prescribed despite being ill. I also advised him on monitoring for signs of aspiration or difficulty swallowing while eating or drinking. In addition, I educated him on the importance of continuing his CKD medications, as well as maintaining adequate hydration and avoiding NSAIDs, as those can exacerbate his chronic kidney disease. Lastly, I advised the patient and caregivers to seek help if symptoms are worsening, such as increased difficult breathing, persistent fever, or increased confusion, especially if there's worsening in cognitive function related to declined renal function. Follow-up. Given the patient's existing comorbidities, I've advised the patient to return to the clinic in 3 days or sooner if necessary for a recheck of his labs, with an emphasis on his kidney function. Being that this patient was followed by a nephrologist, I contacted them to make them aware of his current diagnosis and treatment plan. Thank you.